Hello, I am Professor of Colorectal Surgery, Søren Laurberg. I have previously been the President of European Society of Coloproctology, and I'm now only involved in research since I'm an old man. Here you see the picture of our new big university hospital in Aarhus, which is probably the biggest and specialized hospital in Northern Europe. So if we compare Denmark with Poland, we have about 6 million inhabitants. In Denmark, Poland has about 6 times as many. In Denmark, we are divided into 5 regions. The majority of all treatments are done at public hospitals, and cancer can only be performed at public hospital, and everything is, of course, paid by our tax. So, thank you very much for inviting me to give this BJS lecture. You should know there are several conflicts. I am Danish, I am old, I'm a great believer, and my views are, of course, therefore a little bit biased. So, how can you improve things regarding treatment of colorectal cancer around the world, including Poland? First of all, you have to know, what are your status? Can you measure it? What are your 30-day mortality? What are your complication rate? What are your long-term outcome? And you should know that there's a major impact on the volume per hospital, the degree of specialization, and finally, teaching, training, and trials are key. So, you know, in the bad old days when I was a young surgeon, everything was easy. We had no really relevant pre-op staging. We didn't read the pathology report, who cares? We had no oncology, and we had no relevant follow-up. So it was nice and simple. You see, when you look on Denmark between 1980 and 2000, treatment for colorectal cancer, when you look back, it was really terrible. I mean, colon cancer, when I was a junior surgeon, I've never done a case with a consultant because everybody knew that a right colectomy was just an extended appendectomy. And for rectal cancer, we were really late to be inspired by Bill Heald and take up TME surgery. So you see, at the same time, Henrik Kehle, who is a professor of surgery, he pioneered the whole ERAS things in the early 80s, you know, avoiding or reducing pain after surgery, early mobilization, early feeding, you know, really trying to improve early outcome. But you know, if you go back and look into Denmark, there was no reduction in 30-day mortality during these years, and it was very, very high. I mean, we are happy in Denmark. We are about the most happy people in the world, but it came as a great, great shock in 1998. In this publication from Acta Oncologica, we found out, when we compared us to all the other Scandinavian countries, that we were behind. And you see, the unbroken line shows the Danish results, and for colon cancer, and for rectal cancer, and for males, and for females, we were the worst in Scandinavia. After this shock, something really happened. We formed a national various national cancer groups for colorectal cancer, for breast cancer, and for all the other cancers. They developed guidelines, set up standards. All data were transparent, so you could see how each hospital performed. And for colorectal cancer, the Danish Colorectal Cancer Group made annual reports. At the same time, there was a national cancer steering group formed by the National Board of Health to look in more general nationwide and come with recommendations and plans. The major problem with this was that there was no focus on surgery for cancer. So the cancer group, the National Cancer Group, came out in 1998 with national guidelines. And since that, it has changed. In 2002, it included laparoscopic colorectal cancer surgery. And just in 2024, all units must recognize sequelae and set up a way of identifying and treating sequelae for cancer treatment, which is quite common and a major problem now that our patients survive. You see, I was sitting in the National Cancer Steering Group, and in 2001, I got so frustrated because all the things that was going on in the steering group was dominated by oncologists. Just one example, they suggested that all patients with anemia should be treated with EPO, and it cost millions of kroners, as much as we do on research within healthcare per year. So I got so frustrated, so I raised and said, I'm not going to take part in this anymore. I am leaving. Just a month after, we had a new health minister, and he arranged a meeting between politicians and leading experts within healthcare. And Kele, the fast track guy, and we were invited to give lectures. And of course, we phoned together and made a simple strategy. Make it simple so that people can understand it, just count. So one example, in Denmark on a national level, we do about 600 TMEs. At that time in 50 hospitals. That means on average, each hospital would do one case per month. And most hospitals would do less. And to run a service all days, years around, you need 3 surgeons. So on average, each surgeon would do 4 TMEs per year. And then I looked at the leading politician and said, okay, if you have problems with your car, do you really want to repair your car if he only repairs 4 cars per year? Then we left out, and I tell you, you have to fight to change things. And at the coffee break, I was contacted by the most influential person of healthcare, Vagn Nielsen, sitting in the Minister of Health, and he came to me and he said, Søren, I've heard you have retired from the National Cancer Steering Group. Oh, be patient. And I looked at him and I said, no, because as I told you, if you are an expert and those who make the decision won't listen to you, you must resign. And there has just been a major scandal in Denmark regarding Tamil immigrants where the politician wouldn't listen to the experts. You see what happened just 1 week later? Everything changed. And the head of the National Board of Health contacted me and said, oh, Søren, I would like to have an evaluation of colorectal cancer in Denmark from a surgical perspective. I mean, would you be the chairman? I said, I would be happy. And then I had to select 6 members of this group from universities, from regional hospitals, from the east and western part of Denmark. And don't tell anybody, maybe I was a little biased in the way I selected people. I selected the ones with a special interest. Then I made this decision before we make any systematic evaluation, it must be evidence-based. So I found a young surgeon, very bright female in EOS, and I say, go through the literature and look on the impact of specialization on outcome and impact on volume on outcome. And we published 2 articles in colorectal disease, and the conclusion was quite clear. Long-term outcome is dependent upon volume and specialization. And based on the data within these 2 articles, we came up with suggestions. And we said, we don't want to have 50 units anymore in Denmark. We need only 10 to 15 units. We don't want to have general surgeons treating colorectal cancer. We need specialized, dedicated, trained surgeons. And then on top of it, we stole all the MDT courses, primarily, which has been run by the Pelican Center in England. We just stole it. And you see what has happened. If you go back to just 2 years back, instead of nearly 50, we had only 11 centers performing rectal cancer and a little more performing colonic cancer. And then we run a lot of MDT courses, workshop, multidisciplinary rectal cancer, laparoscopic surgery, and recently a fantastic one on colon cancer. We have had on-site visits in imaging, in pathology, and in various types of surgery, TME, APE, CME, and lab surgery. And we have done audit on all these things. And, for MR scans, we went out, and I tell you, in the majority of units, the settings were wrong, even though they have been listening to Gina Brown. The reporting could be better, and the quality of what the MR specialists were doing was definitely too low, and we could improve it significantly just by giving them a little bit extra training. We published that in British Medical Journal some years ago. We did similar thing in pathology, similar thing in surgery, also in oncology, and then we said we must collaborate with specialties within our hospitals, including anesthesiologists and nurses. If not everybody is part of the group, it won't work. It's like in soccer. You must have a good attacker and a good goalkeeper, otherwise it doesn't work. And we should collaborate. So you see, here are some of all the basic persons we have had. For TME, Bill and Brendan, we have had Werner, we have had Torbjørn Holl, and many people regarding laparoscopy because this was a new thing. Gina and Lena Brown in radiology, Phil and Nick West in pathology, and Rocklin Jones and David in oncology. So we have been dependent upon leading experts around the world. So training programs are important, but you need much more. You need specialization, fewer units. You must be certified. You should work together, and you should train over and over. take part in research, and you need excellent registries so you know what you are doing. So, what has been the impact in Denmark over just 20 years? Astonishing. Look at this. This is from our annual report. It shows over 15 years how the 30 and 90-day mortality has decreased. So 30 days in 2001, it was close to 8%. In 2016, around 1%, and it's still at the same level. And similarly, 90-day mortality close to 12%, now less than 3%. So dramatic improvement in early post-operative mortality by specialization, working together and have higher volume. And similar, the 5-year survival, this is for rectal cancer, going up, and up. And now we know that the 3-year survival after intended radical surgery for rectal cancer is not dependent on stage. The only thing that it's dependent upon is how fit the patient is based on scores. So that, people survive now. It's the Charter Index that we have used to measure how well the patients are. And similar for colon cancer. And now we know we have the best results in Scandinavia. But as you know, all countries have improved over time because, things are getting better. But if you look at this, this is a quite interesting publication from Lancet Oncology comparing 5-year survival in 7 high-income countries from 3-5-year periods, 1995 to 2000, 2000 to 2005, etc. And have a look here. You see, these are the 7 countries. The lower one is rectal cancer. And Denmark at this time was the second best in the world at the end, starting up from being in the worst end and now just being second to Australia. And I tell you, no doubt it has improved since. So setting up these things has really dramatically improved how we are doing in rectal cancer. And similar, you can see here for colon cancer, we were at the bottom and now we are number 3 in the world among these high income countries. And maybe we are even better because we probably have the most valid data of all these countries. So why are Denmark in the top for now? I tell you, probably because we were so far behind the other Scandinavian countries, and there is an advantage of being backwards. You get more resources. We implemented screening. We had all the MDT training. They accept the specialization, fewer units and training on site, and we got this team spirit because we as Danes can't live with being in the bottom. The politicians can't. So is it possible in Poland? The basic is really you need high quality data. I'm not sure you have it. They must be transparent so that everybody can see how individual hospitals are performing. And they should include 30-day mortality, complication, long-term outcome. And if you get these data, and if they are not as good as in Denmark, because I can see that Poland is now a really high income country. So you should be able to be as good as in Denmark And if it's not the case, you need fewer units, you need specialization, and you should have teaching, training, and trials. So is it possible in Poland? I don't know. The answer, my friend, is blowing in the wind. The answer is blowing in the wind. So, in the future, I mean, we are going to have more options. We are going to have many more robots. We are going to have artificial intelligence teaching young people and helping during surgery. We're going to have less major and more minor surgery, and we are therefore going to have much more complex decisions. And to be able to perform this, as you know, I'm a great believer, we need fewer units. We must have continuous ongoing training, and we must have an academic approach, more research. So my Polish friends, thank you for inviting me to give this BJS lecture. Remember, specialize, fewer units, collaborate both on a national and international level. And then I would advise you to send young, dedicated surgeons abroad, coming and visiting specialized, very good international units. You know, when I was young, my university paid me to stay for 6 months at the very famous St. Mark's Specialized Hospital in London, and that has been a lifelong inspiration for me. So, friends, I'm very glad to have been able to give this lecture, and I thank the British Journal of Surgery.